I request Dr. Chandrima to introduce Dr. COOTE.
A very warm welcome to Dr. Michael COOTE. So Professor Michael COOTE is a Melbourne-based ophthalmologist who uses cutting-edge technology and techniques to treat people with glaucoma and cataracts and trauma-related injuries. He is also a board director of St. Vincent's Health Australia. He chairs the board subcommittee in research and education and is a member of the board quality committee. Dr. Michael was previously the clinical director of ophthalmology at the Royal Victorian Eye and Ear Hospital, Melbourne. Over to you, Dr. COOTE.
Thank you. I'm not sure that if I knew it was going to be read out, I would have put those things in there, but thank you very much. It falls to me to have this last thing and following these people talking. It's a remarkable privilege. And I'm so glad I didn't actually venture into yoga and new treatments as well. Thank you for the previous speakers. Just as a general wrap-up though, we did hear from Shan Lim about the different things that you can do for patients, and clearly there's a lot of interest in that, and patients shouldn't go off on a tangent. A confession, I guess, is that I'm very much a plumber, and I think that the outflow problems of glaucoma are the one thing that we get paid to fix. So talking about other things is important, but I'm very much focused on outflow. There are new medicines, of course, new drug delivery systems as well, and some of the side effects of the medication may go into that. We haven't gone into genomics and proteomics, which are things that potentially may yet have some light of day. And of course, the surgical options have increased enormously over the years. There is angle surgery, there's suprachoroidal surgery. I'm going to talk a little bit about a different strategy, which is really a refinement of subconjunctival surgery, which turns out to be the only thing that has been proven to work over a long period of time. We start with this concept, don't we, that no one should go blind from the disease. And of course, we all know that it's a really difficult road sometimes to prevent that from happening. I want to share with you a case just to sort of bring us back to why we do what we do. This is a girl who is 11 years old from East Timor, which is just north of Australia. She was discovered somewhat by accident having poor vision, worsening, diagnosis of aniridia, and went on to everything that was available to her at the time, but still couldn't come down in pressure, and so she came to Melbourne. And of course, if you think about someone who's in remote communities with very high pressures and with a disease that's affecting a large amount of the anterior segment, her outcome with no treatment or with current treatment is very poor. Bilateral filtration surgery would be extremely difficult to follow up. It would be difficult for us to do that safely. We could trial glaucoma drainage devices in both eyes, but she may well get diplopia. It's likely that we'd have an effect on her cornea, and corneal grafting at that distance is not going to be possible. This is a very apparent, it's a very real problem for her, but in fact a lot of these issues exist in every population that we treat. There is proximity issues and availabilities. And so if you consider this as a problem of risk, all of the options that we have are risk-based. Post-operative management of risk in glaucoma surgery involves skilled people who often have to see patients very frequently. At the Eye and Ear Hospital in Melbourne, where George and I work, there's an average of over 12 visits in the first year for a patient having a trabeculectomy. Now, for someone in East Timor in the hills, that's just not an option. And we need those because we need to keep guiding this operation into a space where it's functioning. There's a high rate of return to theatre compared to other eye operations. There's a high post-operative intervention rate. And if you put them more formally, of course, what we've got is a cumulative proportion of failure. We've got encysted blebs, we've got bad and uncomfortable blebs, we've got post-operative interventions, 5-fluorouracil and mitomycin, we've got exposed tubes, the number of visits, endothelial cell loss. And these are all things that are apparent to all operations. And of course, trying to navigate through all of that tends to be a problem for all of us to try to create a safe option. The most important safe option is that we get it to target pressure. And we can't engineer away failure. We have to understand what happens. That's Richard Feynman, of course. Richard Feynman was a fellow who was employed by the government actually to look at why the Challenger disaster occurred. And it came down to a single issue, which was the silicon was wrong in the O-rings. But of course, NASA at that stage said every part on the space shuttle had a 1 in 40,000 failure rate, and there was 40,000 parts. The maths was therefore that it would fail every time. And Feynman argued that's completely wrong logic. And understanding how you apply risk is hugely important in clinical medicine. So just to bring you back to the light on the hill, surgery is about outflow, and what you are trying to achieve is 2 microlitres a minute outflow at 10 millimetres of mercury. That is your aim. That is your light on the hill. That's what you're trying to do with every operation you do, possibly also with medicine too, by the way. What we tried to work out many years ago was why that wasn't happening. What was the issues? And if you go into computational engineering of glaucoma operations, you end up essentially coming to 3 conclusions. There are 3 parts to the outflow. One is egress. You've got to get it through effectively a waterproof wall of an eye. The second is you have to laterally distribute it in tissue. And the third is you have to absorb it. This is aqueous, 2 microlitres a minute at 10 millimetres of mercury. And it turns out the most important problem is lateral distribution. It's porosity of tissue. Tissue porosity is what frustrates every operation that we have. And we have euphemisms for it. We call it scarring, and we call it the patient's fault usually, bad aqueous, all sorts of different things. But in reality, aqueous is not meant to be in your subconjunctival space. In fact, free fluid is not really meant to be in any tissue space. In fact, if you think about it further, the only tissue that remains passively porous for the whole of your life in normal circumstances is your trabecular meshwork. It's the odd one out. So just making a hole in your eye and expecting it to continue to work is somewhat foolhardy. So that was our first observation. The second observation is if the most important issue in glaucoma surgery is to actually know what the porosity of tissue is. We did not have an animal model to look at that. So we built an animal model to look at the tissue porosity, and we demonstrated unequivocally that hydraulic stress of anything, by the way, not just aqueous, kills hydraulic conductivity and does it very, very rapidly in rabbits. Now, it's not the only problem, but tissue porosity ends up being a hugely important problem. But there are high failure rates, and again, this depends on how you look at the problem. There are high complication rates, hypotony leak, poor patient experience, inefficiency for the patient, for the support people, you know, the triple, quadruple bottom line of people travelling all the time, the pollution to the planet. You know, it's almost impossible to do in remote or global settings. Glaucoma surgery is something, unfortunately, you know, really congregates around, you know, where people are with skills to help people. So we set about trying to create something that would address these problems. An evolution, not a revolution. I think we understand that we can make glaucoma surgery work. We just want to do it more reliably and have it available to people in Timor-Leste, as well as to a whole of other people. I love that squiggle. Whenever I give this talk, there's a sense that somehow we knew how it would end up at the end of it. You have no idea what these things will look like as you start this process, and it is the first implant, experimental implant I put in was over 34 years ago, so you know, I've been doing this a long time, so it looks very much like that and probably worse. But it has landed now on this. This is called a VW51, which is intended to imply that there are not 51 previous versions of it. There's certainly quite a lot of previous versions of it. But I'll walk you through a little bit of it anyway. The first is you really have to have a tip that seals. In other words, as soon as you put a hole in the eye, if you get fluid flow around the side of it and not through the internal lumen, then you have no control over the process. So I often teach my fellows to try to work out how much is 2 microlitres a minute at 10 millimetres of mercury. And if you look at it, you know, what happens at the end of a trabeculectomy, someone will pump the eye up to 40 and you get a flush of fluid. 2 microlitres a minute is a barely wet joint. It's almost imperceptible. So a lot of the language, unfortunately, we've used, things like aqueous jets and things, are really incorrect. There's no jetting, there's no real flow. It's very much just seepage. Very low levels of fluid, but you have to control it. The second observation is that you don't want aqueous in the front 3 millimetres in front of Tenon's insertion and the limbus. It's the easiest place to put fluid, it's the easiest place to drain it, and it's the worst place from the point of view of comfort and safety long term. So what happens if you make a limbal hole? That's where it ends up, unless you do certain things to try to make it go backwards. So this is an attempt to make sure that this goes back. This is about 20 millimetres long and will lie between the recti, and ends up depositing fluid preferentially at the posterior end, which is why you've got the dye coming out of it. And it does so with a graduated resistance coming back to the front. And there are a lot of holes. Single points of egress are obviously very problematic. So things like presoflows and Zens have suffered from the fact there's a single point. So how did we do with all this? We've now done 2 studies. One is a primary study in humans looking at safety. The second now is a multi-centre study looking at its efficacy and safety over 12 months. And this is somewhat of an amalgam of things, but it does involve the first study, so you'll see a couple of outliers which are due to our experience. But the first is, did we get our calibrated resistance right? So did we get the internal resistance of the device, and did it not leak? We could prove that by the day 1 pressures. We really get a very tight clustering. Now, just to be clear, those dotted lines on that graph are the absolute minima and maxima. That's not a mean deviation, that's everyone. So no one had high pressure on day 1, and no one had anything other than numeric hypotony, and there was only 8% of that. So we have, I think, managed to create the day 1 predictability that we were looking for, which is to know how much resistance you need, essentially in principle. Now, just a moment of discussion about resistance to outflow. The more resistance you have to outflow inside the device, the higher the end pressure, because it's additive. So you can make a higher day 1 pressure, but you'll end up having a higher long-term pressure. So you have to be just a little bit careful. You try to get a sweet spot, which is that it protects against hypotony but doesn't jeopardise the long-term efficacy of the device. Do we have long-term predictable pressure control? Well, yes, we do. That spike in the middle was in fact one of the patients that eroded. I'll talk a little bit about that, but for some reason, if they erode and come to the surface, a problem that we think we've now resolved, then in fact the pressure went up, and that's probably because there's a degree of inflammation around it. Out of the now 65 patients that have been done, we've had no reoperations for intraocular pressure rise, and over 90% of people remain on no drops at all. Initially in the study we had some people having anti-metabolite injections, and in the new study we've had just the 1 out of 40 patients. So it seems like the reduction in post-operative care is also part of it. But multiple points of egress essentially distribute the fluid load. So you don't put it to a single point, single points of egress. Device blockage, we have multiple channels within it. The channels are really quite small, obviously, so all of these things. And you do, those of us who still do Zens, you do find the odd Zen that actually has a luminal obstruction in it. They're 45 microns. This is made out of silicon, so this is not going to adjust and it's not going to kink, but it's certainly possible. We also have a lumen that's angled away from the iris, so that the tip is not possible to block. Protection of the endothelium, we do that by having a very short entrance. So the tip of this is only about 1.8 millimetres long, and the anterior end just enters the anterior chamber. There's no movement, and it is in fact below the. So we've had no loss of corneal endothelial cells in any of the patients we've looked at. And avoidance of erosion. Now this one we did not get right. Unfortunately, initially when you use animal models, rabbits don't tend to get much erosion. So you can do as many rabbits as you want, but you won't get erosion if you're using devices. This was, the first version, VW50, was a little oversized and tended to kink a little bit. So in fact what we tried to do is narrow it, so VW51. We are in fact in the second study using a scleral graft, which we think we'll be able to get away with. Patient experience, there's comfort, there's certainly rapid visual recovery. They don't have any reduction in intraocular pressure, and there's almost no egress of aqueous at the time when you put a 27 gauge in, so there's no inflammatory process. There's a reduced burden of care, so when we look at it, we're getting very little change between it. We've not had any sudden rises or any sudden failures, things that unfortunately have plagued suprachoroidal shunts. So you may be able to stretch out your review time significantly, which I think is hugely important for all of us in glaucoma surgery. So just back to our girl from Timor-Leste. She had simultaneous bilateral surgery under general anaesthetic. Her day 1 pressures were 7, her week 1 were 8, 2 week were 9, and she returned to Timor-Leste, and at 3 months we have her pressures at 11 in both eyes on no medication. She stopped steroids at 4 weeks and was comfortable. Given all the things we've heard, I think the future is bright. There's lots of things on the horizon, I'm a plumber, but there's lots of other smart people around to answer other questions. Is there anything I can help you with?
At the completion, any one question on this new innovative design from Dr. Coote from the
Can I
panel?
ask
Yes.
it? How does it differ in extent of, because you are still entering the antechamber and putting it in comparison to the, suppose, pulse implant, which is supposed to be thinner tube, and they claim that the complications are less because of the thinness of the tube.
It's a much smaller tube than a Paul.
Okay.
Yeah, goes through a 27 gauge, and it, instead of the Paul tube can be quite long. So with standard glaucoma drainage devices, you anchor the plate and then you place a tube in. With this, you have to anchor the tip, and then the plate, in effect, follows. The tip is designed so that only the very smallest part will enter the eye. But it seals because it has a biellipsoid shape, so there's no fluid flow around the side of it, and there's no need to stent it. It has its internal resistance. It's meant broadly to remove that degree of variability, which is... does that answer that question? Yep.
Hope we will see it soon in the market.
You never know. Thank you.
So we have